Yeah. Yes, I will watch the chat, so don't hesitate to put your questions in. Got a lot more people coming.
Yeah.
Kirsten, you're sitting outside. It must be lovely. Is it warm? Yes, you're on mute, so if you're talking, I can't hear you, but you're shaking your head, so it must be warm.
Yeah, it's beautiful. I was just so I had a little trouble logging in. There was an email that came out, I think today, that the Zoom link is not working. So
Oh.
I was just chatting with Hannah Galvin. We're from Cambridge Health Alliance. Yes, it is absolutely gorgeous. I highly recommend everyone go outside right now if you can.
Yeah, I see the sky is clearing.
But no,
Yeah,
no,
it's
I
actually
want
really
everyone to
beautiful
attend the
afternoon.
session, Kristen.
Yeah, after the session, yeah.
Well, I will be discussing from outside apparently. I'm in the YOLO mood right now after COVID. Like, we have to grab the little things. If I've learned anything from that horrible year and a half, it's that you never know.
You never know.
So anyway, I just wanted to let you guys I just didn't know if you realized that if people are having trouble joining, it may be because the link from the email today or yesterday is actually not active. And so I had to go back a couple emails to find the link that
Oh.
worked.
Oh, no. Hope that's not a big problem. Does anybody else have had a problem logging in?
No.
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 No, okay. Well, we'll keep our fingers crossed.
But I used the original link. I didn't, so I don't know.
Hmm. Marlene can hear you, Amita, if you want to talk to her. Hi. Hi, welcome everyone. Hi, Katrina.
Okay. So I did send a message to Marlene, but I think we'll give it a couple of minutes and then we'll start off and we'll just.
Marlene is actually on. She's hiding behind the logo.
I know, and
Okay.
it's just in terms of, because she's admitting people, so I wanted to make sure she saw that as well, that there were issues with the link. So, if
So
people needed to
now
be
Hannah
able to-
has a nice background, but it's fake, right, Hannah? You're not really outside.
Yes, it is, sadly.
Yeah, so it's nice, but it's not real.
Okay.
Hello, everyone. Oh, Carolyn, hi, I didn't see you there. Hi, how are you? Another minute, Amita?
Yeah,
Okay.
just. All right, why don't we start off and others will join us when they can. Hi, everyone. Welcome to our panel discussion on realizing the potential of digital healthcare. I'm Amita Soni, and I drive growth for tech and digital health companies as a strategy consultant, interim chief marketing officer, and board director. I'm going to be your moderator this evening. My thanks to Bev Brown, who organized the program. Bev is traveling this week and can't be with us today, unfortunately. Marlene Favlarov is with the Boston Club and is helping us with the logistics today. So before we get started, just a few housekeeping items. Our program's going to run until 6 o'clock. And we're going to keep the last few minutes for Q&A, but feel free to have put your questions in chat. So I'll weave them in as appropriate during the panel discussion as well. And we're going to be recording the sessions as you saw in the notification. And during the session, everyone except the panelists will be muted. So what's digital health? It includes mobile health, health IT, wearable devices, telehealth, telemedicine, and personalized medicine. Applications range from wellness to medical devices to improving the ability to accurately diagnose and treat disease and improve healthcare delivery as well. Certainly with the COVID-19 pandemic, we have seen an explosion in digital health adoption. Patients are using telemedicine, physicians are using AI-based applications, patients are ordering prescriptions online. So there's a whole lot of different applications, and yet we still have a lot of challenges, whether it's data interoperability or reimbursements and ROI related to this, personal connections between clinicians and patients, and equitable access. We have a terrific panel today to help us better understand how we can address these issues and realize the potential of healthcare. To maximize time for their comments, I'm just going to do a brief introduction, and we have their detailed bios, a link to their detailed bios available in chat. So Jane Boymel was until last week with Optum Labs as Senior VP of Partners and Programs. And as of yesterday, she's with the Enterprise Analytics team at CVS Health. Piali Day is CEO of Sensio Systems. Emma Foss is CEO of Medical Informatics Corp. And Brian Jack is professor and former chair of the Department of Family Medicine at Boston University School of Medicine. So Jane, Piali, Emma, and Brian focus on different aspects of digital healthcare to improve health and save lives. And they're here today with us to share their perspectives. I thought we'd start off by having just a couple of quick polls to help them better understand the audience. So Marlene, if you can help put up the first poll for us, please. We'll give people just some time to answer the questions. Marlene, so that's, yeah. I think we can, let's go in the poll now so we can just see where. So certainly all of us as individuals, whatever our business lives and business roles are, certainly as consumers or patients, but then also some certainly from a clinician perspective, and others are just interested in the area, in the topic itself. So let's do the next poll. Yeah. You can see that as well. So Marlene, let's do the next poll now. Yeah. What are the constraints for digital healthcare adoption in your mind? So just even if you're not involved in the healthcare side of things, just what do you think? So we can end the poll. And what we're seeing here is kind of interesting as people look at it. All of these things are pretty much issues that people think will affect the adoption of digital healthcare. So why don't we take now just a few minutes for each one of our panelists to talk about how they are connected with digital healthcare. Jane, should we start with you?
Sure. So it's wonderful to be here this evening. And as you just heard, I just moved from one organization to another. So I'm not really representing any organization. What you're hearing is, my opinions based on, sadly, my many years in healthcare. So with respect to the interaction with digital care, my perspective is really going to be from the data and how we use data and how we want to use the data that's generated from all these devices and from the new ways that patients and clinicians are interacting. As you can imagine, the sort of the holy grail of data is always how new is the data, or is the data real time? And that is the exciting part of digital health, is that we may get information more quickly, more readily, and etc. So my connection to this has been both from a retrospective perspective and of course from a prospective angle as well. So from retrospective, when I was at Optum Lab, we were working in a research collaborative and using data to study trends and to understand what's going on in healthcare. So getting different data, using different data assets, such as data from a continuous glucose monitor, or even a Fitbit or something like that, can be very valuable to rounding out the story of a population. And then looking ahead, looking at predictive analytics, and the same thing applies, is the more differentiated data assets you have, the better picture you have of a particular population. I think I'll stop there.
Thanks, Jane. Viyali?
Thank you for this opportunity to be with you. This is exciting, a fun time of the day for me. So my experience with digital health is primarily from the consumer's perspective. By way of background, I'm a physicist, and while I was in graduate school, I became very interested in artificial intelligence. And after my usual academic route, I decided that I really wanted to do something with AI. And I went to the defense industry. And for about over 20 years, 25 or so years, I was involved with the application of artificial intelligence to improve our military command and control systems. And it was a fantastic time of my life, very privileged to be able to work on behalf of the folks who defend us. And then about 10 years ago, happened to realize by looking at our aging parents that what I saw in the battlefield, the ability to connect a lot of disparate data and make sense of it and make a correct command and control decision at the spur of the moment, I noticed that those things were happening in every kitchen. Our parents were overwhelmed with their health and just an inability, a paralysis setting in as to what do I do? What am I supposed to do today? Who should I talk to? What should I do? So we started this company. It's actually my husband and I. He too is a physicist by training. We started this company saying, we know a lot about AI. We know a lot about medical devices. What if we could combine those two things and bring them into the home? Could we help our parents to stay on top of their own care with the assistance of artificial intelligence in the home? So my connection to AI and all my passion is around how can we bring AI into the home to assist those whose cognitive ability can no longer keep up with their cognitive need. And so that's my relationship to it. It is the best problem that I can imagine solving. And I feel so privileged to be able to work on that.
Thanks, Piali. Emma?
Hi, everyone. My relationship to digital health is that I am a co-founder of a company that specializes in real-time clinical surveillance technologies inside of hospitals. Effectively, we help collect real-time data from a lot of the devices connected to patients that are in a hospital. And we help time synchronize and normalize that data for applications, whether that's retrospective or real-time clinical surveillance, or just the ability to remotely monitor patients. A lot of my personal interest is in actually understanding how to get transformative technologies out into the world and help them be realized. And I've spent the past 10 years helping sort of bring this technology to bear in the healthcare industry, and we help support some of the top hospitals around the country, allowing them to leverage this data that's been traditionally deleted or lost, and scale some of the AI in a way that they can operationalize it across their entire system. So with that, I'll sort of pass the speaking stick on.
And for you, Brian?
Thank you, Amita. It's a pleasure to be here with this panel today. My connection to digital health is mostly through my research. And that a few years ago, our team developed what we call Project RED, which is the Re-engineered Discharge Program, which is a process designed to help educate patients in the hospital about what to do to care for themselves when they go home from the hospital. It's a very big topic in health reform to improve quality and to lower cost. We then developed a conversational agent system to teach the re-engineered discharge in the hospital. And conversational agents are animated characters with tailored speech designed for health education. And the bottom line of our studies show that for Project RED was that patients prefer to get their discharge instructions from the conversational agent Louise than from a doctor or for a nurse. And then with that, we designed another conversational agent system in women's health, and that's called Gabby. And Gabby identifies 100 health risks and then works with a woman over 12 months in tailored dialogue in a series of conversations to lower the health risks related to those issues. And we just published a randomized controlled trial in The Lancet in September, showing that the conversational agent technology can lower health risks by 16% compared to clinical usual care. And it can be used as an adjunct to clinical care or as a population health tool as well. And then most recently, I'm working with John Woodson at BU on a report for the Biden administration around digital health and what the recommendations are for what needs to be done at the federal level to move the whole field forward. So we're excited about that. That will be submitted in September. So I've been doing a lot of thinking about this.
Great, thanks, Brian. So my first question for all of you, as we've all seen with the pandemic, it's really accelerated the adoption of digital healthcare. What have you all seen so far? And most importantly, what do you think is going to happen post-pandemic? And what aspect of digital healthcare do you think is going to get the most traction going forward? Emma, when we start with you.
Let's go. So it's very interesting. You know, the pandemic, what it did in many ways was transform the acceptability and the idea of the barriers that you had of acceptance from both sort of your practitioners and your administrators of digital health. People and systems were overwhelmed, and they needed tools to augment and amplify their workforce effectiveness, right? And so they often turned to digital health tools that they had started piloting, that they had started, they had some experience with, and then they went and rapidly scaled
How are
those.
you? Oh, good. You're
And-
open to mine. Good. Good.
We're getting some feedback here. So with that, I think that a lot of the
Yeah.
traditional barriers for a lot of digital
No.
health were removed. So
Excuse me 1 second. If everyone else can please put themselves on mute, please. Anyone who's not talking. Go ahead, Emma. Sorry about that.
oh, I was just saying that I think I was going to comment. It was just basically that a lot of their traditional barriers for accepting digital health were removed, and what you saw is a rapid acceleration and adoption of a lot of digital health technologies to augment the workforce. I think there's some barriers that came up as well with sort of resource limitations, but I know we'll probably touch upon that a little bit later as well.
Mhm. What have you seen, Jane?
Well, one of the things that I saw and heard about from my colleagues was, the substantial learning curve that happened both from the, clinician perspective and from the patient perspective. And, I even here's an anecdote for you. I spoke to a physician who's been practicing for like 25, 30 years. He's like, I know how to practice. He was a pulmonologist. I know what to do, but he had never done a virtual visit. So it was completely new for him. And, now fast forward, he's totally comfortable. And, to your question, Amita, like what happens now is now we can start getting some return on that investment that everyone made during this time, and trying to find the right balance between when we should be using the virtual care or telemedicine, whatever term you want to use, and when it makes sense to do the in-person visit. So before we went from 0 to 60, and now it's sort of like where should we be on the spectrum?
So as a physician, Brian, what have you seen and where do you see things are headed?
I mean, it really changed our lives a lot in how we do things still. And the technology of telehealth has been available for quite a long time, but there are a whole variety of clinical and administrative barriers for its use. And I think that without telehealth, without the pandemic, that telehealth would still not be used nearly as much as it is now. And that in the early days of the pandemic, there was a whole series of activities that happened very, very quickly that would not have happened without the pandemic. For example, just even scheduling, how to schedule patients for telehealth visits, and all the workflows associated with like you had mentioned about the pulmonologist friend. All those things took time to learn how to do it, and the documentation systems and the EMR, the video, the HIPAA compliant video systems, the malpractice policies that were reformed, new billing codes were created, and new patient safety and quality metrics were developed to measure the quality of what we were doing. And all that happened so quickly because the necessity was really the mother of invention in this case. And then we found that people like it, that patients and doctors like the convenience of it. And the data has showed that people are less likely to miss visits if telehealth is an option for them, that physicians feel comfortable with it generally, and often will schedule patients for quicker follow-up afterwards. And that telehealth is very good for some things, like for chronic disease management, and for medication refills. And even for a lot of educational sessions and conversations about things, the telehealth has been very successful. But we're now finding, and we can get into this later, that a lot of these administrative changes that were put in place quickly are being pulled back, and And it would be a shame that if we had to start over in terms of telehealth. And I think for a long time, I thought that it would continue as it was. But I'm really seeing signs now that we're moving back to where we were. There's a big push to move back to in-person visits.
Piali, I mean, you work a lot with chronically ill patients. Would love to get your perspective from that point of view.
Thank you. So our platform always had remote monitoring in it. And before the pandemic, we were monitoring the health of people with COPD and heart failure and diabetes and hypertension that vary the highest risk population. I remember that as soon as it became obvious that the pandemic was here in the United States in the middle of March, we were scheduled to go off to a vacation, but 3 days ahead of the vacation, we very quickly added to our platform a COVID monitoring protocol. And it was out there with all our members, we don't call them patients, in just 3 days, because they already had the devices. They had the thermometer, they had the pulse oximeters, because they were using them to monitor other aspects of their health. So that was transformative for us. And the second thing that we discovered during the pandemic is the loneliness piece. So we've always had remote monitoring. We always had a light touch on coaching, but with the pandemic, we doubled down, and instead of calling someone only once a month, we started to check in on them once a week. And with all of that, I'm so happy to say that with the sickest of the population, only 1% picked up COVID, and none of them needed to be hospitalized. A couple of them were sent to the hospital by their primary care physicians. They went with their tablet, and the hospital sent them back home to recover, and everybody recovered. So we saw firsthand what you can bring to the home if you had that constant remote monitoring, coaching, and it was crazy. In RAI, in terms of conversation and stuff, is still very rudimentary, but we found that our members were talking to their devices, their isolation. I mean, they needed to anthropomorphize this thing just so that they didn't feel, they felt like there was something with them. So we saw some just deep stuff happening in the home as people struggled with feeling stranded, feeling scared, feeling lonely. And I hope we find a way to keep nurturing some of that as we invariably go back to more face-to-face care.
So, so digital health, certainly telehealth has been a big part of it through the pandemic, but digital healthcare is more than telehealth. Mm-hmm. So as we think of that in a broader spectrum, where do you see the value, the most value going forward, and also the biggest challenges? Maybe if a couple of you want to take a crack at that.
I think some of I think when people think about healthcare, and especially we deal with in-hospital a lot of the time, we think of very advanced technologies. But the reality of it is actually there's a lot of service lines, there's a lot of operations that go in hospitals that are still very manual. And so what digital health often offers is ways to optimize and improve efficiencies of the way care providers operate in that environment, whether that's simply doing a daily task, such as automating something that's a manual process where they print out strips, to helping to identify things that they should focus on and direct their attention to. The second bucket of things I think is really out there is in the category of using digital healthcare to augment and improve what we do beyond what we can sort of physically do or mentally do as humans, right? It's that predictive care, it's that precision medicine, it's looking at the data from an individual patient and being able to tease out the minute-to-minute, hour-to-hour insights that can help drive and optimize care and ultimately improve outcomes. So I think those are two areas that we'll see a lot of advancement in, and I think have a lot of potential. And then to your point about barriers for adoption, I think that sort of falls into resourcing. I think a lot of institutions are set up to, from an operational standpoint, they're not set up to be innovative. They're set up to, especially IT infrastructures are set up to be reliable and continue to do what they're doing. And so I think, Brian, even what you were saying earlier, which is, the institutions are going back to what they want to, like what they did before the pandemic. It's because a lot of that institutional mechanisms for providing the care that they provide are very well established, and that room for innovation, trying something new, adapting to that new potential of how you can deliver care is a very hard transition, and there's not a lot of resources available to allocate to that activity. So,
what do you think, Jane, on your end?
Well, I had mentioned in my opening remarks about the value of the data. So, I believe that that is still true. I think the challenge is going to be the trust that is going to go along with that. So are the consumers of that data willing to entrust others to use that data appropriately? And so I think that's where we're starting to see some barriers at this point.
So moving on to another question, the factors beyond technology itself, which affect the adoption of digital healthcare. How does one overcome the reluctance and gain acceptance with all these different constituents in healthcare, whether it's the patients or the providers or the policymakers, the payers, the regulators? There's so many different constituents. What do you think, Brian? How do we go about that?
Yeah. So, my view is that, as many have said tonight, that many of the technologies now exist, and I think it's really about setting up the incentives in the health system to make it happen and to do the implementation parts of it. And my sort of view of it is that, and I think it's a very important point, that I believe that digital health, unlike in other sectors of the economy, but in healthcare, I think digital health is necessary for health reform to be successful. It's a really important point. And that the transition to value-based care from our fee-for-service model. So value-based care meaning reimbursement based on capitation, quality, and satisfaction, not on visit-by-visit payments, is needed to incentivize implementation of many digital health technologies. And I'll tell you what I mean by that. And that the value-based care incentivizes population health, which is very different than what we do now. So if right now we get paid visit by visit, it's value-based care, we get paid by a defined population plus quality plus patient satisfaction. That will incentivize us taking care of a denominator population, meaning that not only would I take care of the people who come to see me, so the half of the people that come to see me, I think I do a pretty good job taking care of them, but I don't do a very good job under the system taking care of the half of the patients who don't come to see me. And I would make the case that our communities will be healthier, not by incrementally improving the care for people who have good access to care, by taking the half of the patients without access to care and bringing them into the system. So if there are financial incentives to deliver population health, why is digitalization necessary? And I would say there's a lot of things. So digitalization, for example, even something as simple as patient registries. If you talk to doctors now, they can't even give you a list of who their patients are generally. As in many other countries, and we've read in the newspapers about places around the world that have, can send emails to all their patients and do studies on those patients. And also, and telehealth by itself, because fee-for-service system is a disincentive for telehealth because you have an incentive to bring people in to see them face to face. And also digital health in the home, of which there are, as mentioned, many new technologies that are ready to go, but that are not right now incentivized to take the care out of the office and put it into the home where it can be done much better oftentimes. And also to incentivize platforms for team-based care. For example, behavioral health integration, very important, but that is not also incentivized under the current, incentive system. And then also monitoring of key quality and safety metrics requires digitalization. And also using the patient portals to push information out to the population rather than waiting for people to get sick and come in for care. And then finally, simply a digitally connected network of hospitals, doctors' offices, health centers, nursing homes, rather than the fragmentation that we currently have, is necessary for health reform and population health. And especially for complex, high-cost patients. And it's very clear now that ACOs and capitated models, to be successful, have to control costs on those highly expensive patients. So I think it's I think it's true that these activities are needed for health reform, and that digitalization is needed to implement the activities that will make it successful.
Piali, you've taught quite a bit and have some specific thoughts around how digital health is tied to healthcare reform. Would love to hear what you have to say.
So I'll go back to what Emma said a while ago, and I totally agree with Brian. Digitalization of healthcare is essential for reform. And I'll come at it first from the perspective of automation. So much of the care that, for example, primary care could be providing. I mean, we know there's a shortage of primary care capacity in the country, and it's only getting worse. It can be automated. Simple examples are remote monitoring, obviously, is an automation that can happen. Education, coaching. AI can do quite a nice job of rudimentary coaching. Why do you need to take this medication? If you aren't taking this medication, let me tell you why it's important. Let me tell you what's going to happen if you don't take the medication. So there's just a lot that the digitalization of healthcare can automate and take it off of the primary care's list of things to do. If a primary care physician did not have to call a patient to nudge them into taking the medication, they can focus on the high value care. So I think automation for the routine care will create capacity for that high value care. And then you really can start to pay attention to those complex patients who are not coming into the office, just as Brian said. So creating capacity and reaching out to the ones who are not coming and knocking on your door and seeing you perhaps more often than they need to see you. Those are the two areas where I think digitalization of health is essential. There's no way we get to value-based care, providing care to everybody who needs care at the right time, by the right person, without digitalization of health. It is essential. It is essential.
I agree so much. Thank you.
So what do you see regarding the payer stance when it comes to reimbursement for whether it is telehealth or digital health offerings? Because one of the things, as Brian earlier alluded to, during the pandemic, the payers were providing equitable reimbursement. How does that change, and how do we make sure that the physicians or the clinicians are getting appropriate, reasonable levels of reimbursement as such? Because I think that's going to be a big sticking point going forward otherwise. Piali or Ryan or anyone else?
Yeah.
Start out on that one. I think we're all holding our breath to find out what happens at the end of this year, where CMS ends up with their telehealth policies. And I hope they don't take a hatchet to it and roll everything back. I hope they take a scalpel to it. And if they take a scalpel to it, I hope they keep telehealth for people for whom access to care is already a challenge. Whether it's because they live in rural settings or whether it is because transportation is a huge burden on them or their caregivers. So I think these are all policy decisions. I think if the reimbursement policies were around factoring someone's difficulty accessing care, then I think that may be a good middle ground for the payment to sit. As we wait for CMS to make these decisions, we are actually in some conversation with some commercial payers. And I am getting the sense that where access is an issue, there is a lot of appetite among the commercial payers to entertain a virtual care model. Because just like Brian said, I mean, the people who are coming into the office, they are doing reasonably well. It's the half that's not coming in. And if you're a payer, you can't ignore that half, because that's the half that's breaking the bank. And I think I'm hoping that through this year and through last year, there is enough data to show that if you could get that care into the home virtually, they do better and there's a lower total cost of care. I'm really hoping that people are looking at that data and that reimbursement is tied to poor access to care.
No, I
I'd say that too, that the Affordable Care Act, Obamacare, one of the important parts of it was accountable care organizations, and accountable care organizations are basically value-based systems with denominator populations caring for the entire population. What we have to get away from is, and for the last 4 years or so, we've been, of course, the politics of Obamacare, has been pulled back. But what we have to get away from is the mixed incentive environment where we have both incentives to do fee for service, which does nothing but incentivize more operations, more hospitalizations, more consult, all these sort of things to expand the cost of care with very little evidence to show that it improves the quality of care. And at the same time have ACOs with our incentives around value-based care. So the mixed incentive environment is very difficult currently and hard for hospital systems or health systems to invest in digital technologies at the moment beyond what they have to do.
I heard a very interesting HIMSS study that they had done, some results of the study they had done. And they were actually talking about how with telehealth, especially during the pandemic and now coming out of the pandemic, during the pandemic, they saw everyone in every age group using telehealth as such or other digital means. But after that, they're seeing it's the younger generation who's looking at it more from a convenience factor. And whereas for the older people, it may not just be the convenience aspect, but the fact that they have more complex care conditions, which require seeing physicians in person, that you're seeing a little bit of a division in there in terms of who's actually going to use it. So we'll have to see how that works out. But one of the other things which is going to make a difference as well is, which again was eased during the pandemic, was this cross-licensing. Yeah. And being able to, when dealing with things digitally across state border lines, whether it is in terms of mental health or other issues as well. And what do you think is going to happen there, Brian?
Yeah, so Boston Medical Center, they embrace telehealth greatly, and that the number of visits went up tremendously. So telehealth accounted during the pandemic, since we can say it's over now, I guess, since we're not in a state of emergency in Massachusetts anymore. That pandemic that was long ago, that 35% of all primary care visits were done at Boston Medical Center with telehealth. But still, overall, the total number of visits decreased by 20%. So even though telehealth was used a lot, overall there were fewer visits. And there are now articles coming out about how that has impacted health in stroke rates and heart attacks and various things, that the chronic diseases especially were not cared for so much. I think that the future is, during the pandemic, we had to set up protocols for the nurses. So when patients called, to talk with them and to make a decision on the spot about, is this an appropriate telehealth visit, or does that person need to come in? And normally it would be, if a physical examination was necessary, then they would have to come in. So I think that there is a lot happening to overcome that barrier. And I think the next few years we'll see more technologies. So telehealth, you can talk to a patient, but you can't examine them. And so there'll be technologies where you can get information, even things like vital signs, from the home that can be, sent right away. And then also, video laryngoscopes, for a variety of things, and digital stethoscopes, and photography of the retina in ophthalmology, and high resolution cameras in teledermatology, and smartphones to do a whole variety of things like monitoring depressive symptoms and other things like that, and heart rates. And there's lots of training programs now. It's impacting training in terms of fellowships and residency programs to train young doctors about how to do these visits. So all that is happening pretty quickly now.
So Jane, I have a question for you. As we heard, AI has the potential to revolutionize healthcare delivery, yet there's a real possibility that the AI tools train with the data, which reflects, there's some historical and cognitive biases built in there, which can make this whole issue of access a real issue when it comes to healthcare delivery. How can we rectify this issue?
Well, this is a great question, and we could have spent the whole time on this topic alone, but there are so many topics related to digital health. The first thing I'm going to say sounds so basic, but I think it's really important. When you're using AI, you're using machine learning, you're using the tools, you really need to be curious. Like, you have to ask questions about what you're using, like what data has gone into this tool, like, asking the question, like, what's the provenance of the data? What's the timing of the data? Like, as we go forward and people start looking back, think fast forward 10 years now, and someone says, oh, I want to look at a population and I want to look back 10 years. Well, they need to remember that 2020 and 2021 weren't normal years, right? So just things like that. But, both Brian and Piali made a good point about the patients or the people who are not in the system, right? And so if you're trying to create a model, let's say, looking for the high utilizers, and you look at all the people who have cost, right? You use the cost variable. The people with all the, and you say, okay, all the people with the high cost are the people we should talk to, or the people we should target, or the people who are important to a particular program. But there may be people who are high cost who were not in the system because they didn't go to the physician, or they didn't show up at the ER, or they didn't go to urgent care, or they didn't go to the, have a visit, a telehealth visit. So you just need to understand what the data is. And maybe there's other data that can be used, right? When you're looking at cost. So those inherent biases or systemic biases may come in the form of the data. And that's why you need to ask the questions. But you also need to ask the questions on the other end. So after you've applied the tool or created the tool, the person on the other side is making a decision based on this data or the output of this model. So again, you have to ask the question, did the model work as intended? Did the algorithm account for something that was unintended? And that's okay, as long as you know what happened. So that's why asking questions and being curious is really important. I will refer you to a great article that was in the New England Journal in August of last year. And it's called Hidden in Plain Sight. Can't even read my own writing, sorry. Reconsidering the use of race correction in clinical algorithms. this was a powerful article that pointed out some of the inherent, racial decisions that were made in some of these existing models, and that have just perpetuated some of the disparities and inequality in healthcare delivery. And that's why I say you have to ask the questions about what went into the model, because otherwise these the systemic element, systemic racism in these models will keep on going.
As Jane put
I
it.
think, I was going to say, I think Jane brings up a great point. But I do want to distinguish, I think it's important to also distinguish there's different types of models right out there, right? When we talk about AI, essentially what AI is, for most 90% of the AI out there, it's about teaching a computer to recognize a pattern, right? And so I think a lot of people are familiar with like cancer detection. So you take an image and you train an AI model to recognize cancer, right? That's much, depending on those type of models, much less likely to have bias on them because they're really looking at chemical structures, shapes, things like that. They're based on physiology. Whereas a population model of care pathways and things like that is much more likely to perpetuate bias because the system that it's trained on or the pattern is trying to recognize is already on something that has inherent biases in it. I think there's actually a lot of ways to look at innovation with bringing AI into looking at physiological data, signal processing, things like that, where it's really based on some of the fundamentals of how the body works versus, treatment plans and the way that people have influenced that care. So I just want to put that out there and sort of bucket it for people to think about when they hear about AI, when they look at AI, when they become curious about AI. That question of what questions were they asking? What were they trying to get the computer to recognize? And what was the data they were trained on is a great place to start for dissecting that and understanding the impact of it.
And I think just the just overall being cognizant of the fact that this bias can be introduced and just thinking about it, it makes a difference whether you're choosing the data set or how you're reacting to things as well. So given the time, I have one question for both Piali and Emma, and then we'll throw it open to the audience. So I was going to say, in terms of the audience, if you can start thinking of the questions you want to ask and maybe put it in chat, that would be great. And meanwhile, for Piali and Emma, you're founders and CEOs of healthcare startups. What are the challenges you have seen in terms of commercialization from a healthcare startup perspective, and how have you addressed them? Emma, if you want to start.
I think this is a question that comes up a lot. It's actually really hard for innovation to succeed in the healthcare industry. If for any other entrepreneurs or anybody looking at this space, one of the big challenges, of course, is that the payer is not necessarily the beneficiary, is not necessarily the user of whatever technology or digital health thing you're trying to get out there in the world. And so it creates a very non-obvious path to create a way for adoption and for essentially you're building your business model. So I think that's where I sort of leave it. Piali, you have a different take on that, but I think that's where, people really have to wrap their head around that and really go out and experiment and figure out what works in the, diverse healthcare environment we have.
So I'll say our company is 10 years old. The first 5 years was really easy because that was developing the AI. It was fun and that was easy. But the last 5 years was really, really tough because your product has to satisfy 3 different constituents. It's got to get the consumer to be totally engaged and falling in love with it. It's got to work for the doctors because if they did not believe it or wanted to use it to inform care, then you might as well have not built it. And it's got to work for the payers. And so threading through 3 needles is very, very tough. Now, everything started to change for us when Medicare started to pay for a lot of virtual care. So at least we got the payer piece behind us. And then the hard work was to make sure that the providers actually saw value in what we were doing. And delighting the consumer was never the hard part, because, but they weren't going to use something if the doctors were not going to use it, if their health was not going to get transformed by using it. So answering to 3 bosses has really been tough. But where the game is now, I think it's all about workflow integration. Providers have to easily be able to integrate digital wealth, I would say, because the wealth of data that can be brought to inform care is amazing. Now, how do you integrate that digital wealth into a primarily non-digitized decision-making process is where I think we have to all focus on, and the challenge lies.
Great, thank you. So question for Brian. Can you share a bit more on the work that you're doing for the Biden administration? What is the focus and the scope?
Yes, yeah, thank you for the question. I have a role also in the BU Institute for Health Systems Innovation and Policy. The director of the institute is John Woodson, who is a former BMC vascular surgeon who was in the military, who was appointed as the Undersecretary for Defense during the Obama administration for 8 years. And he ran the military health system. And one of his initiatives at that time was the digitalization of the military health system. So we had a lot of contacts, and it was friends with Joe. So they've had a lot of conversations about digitalization of the health system. And it came up that our institute would put together a list of recommendations for what we think needs to be done at the federal level. And we're framing it as, for example, if there was a HITECH 2 Act. So HITECH was part of the, not the Affordable Care Act, but the act that was put in place when Obama started because of the financial crisis. So HITECH, it was part of that act. And it did things like meaningful use, which helped move hospitals and clinics forward a lot in terms of implementing electronic medical records and using them in a way that is important. And it really did a lot to move digitalization forward. So now we're asking the question, if there was a similar HITECH Act now, what would it include? So they can actually draft legislation. So if you have ideas about in your businesses, if there is something that the federal government could do to make things work better, to incentivize the digitalization of the health sector, please let me know and we can put it in.
So another question from the audience. What technology exists that is still not being used in healthcare? What are we still missing to make care better? How do we get patients to lead this, since healthcare is so conservative and clearly doesn't adopt change easily?
This has to be a consumer-led revolution. There's just no question about it. And I came from the defense industry. It is shameful how little technology is used in healthcare compared to in the defense sector. But it's all the same equation. There we were trying to save the lives of our soldiers. Here we're trying to save the lives of our most vulnerable population. It's still a matter of life and death. There is so little technology that's used in healthcare. It is sad. And I think consumers really just have to wake up to it and say that their lives could be so much better and ask for it.
I just want to put something out there. Like a couple years ago, we go to a lot of the trade shows and stuff in digital healthcare for a lot of the healthcare systems. And I think just a year or two ago, before the pandemic, the hot topic was secure texting between clinical staff, right? So I just want to put that in context, right? So you often have to take your consumer tech and go 20 years back or 15 years back. And that's sort of what healthcare is being broadly adopting right now. So, that it's not so much has one person brought it into the industry and is using it. You're looking at that broader adoption curve, and that's got a 15-year delay on it from adoption standpoint.
We have time for one last question. It says, Brian talked about value-based care, but how do we ensure that there is value-based technology? technology that's not prohibitively complex, expensive, and supports a small population.
Is that a question for me?
Anyone who wants to
Yeah,
take.
yeah, anyone? Yeah. Anyone?
I would say technology has to be held to exactly the same standards. What is the outcome that it is creating and at what cost? So we measure ourselves from a technology perspective purely in the same way that value-based care is being applied to physician delivered care. It's no different. It's no different. Cost has to be a factor in it, and cost has to be measured against the outcome. Treat them all exactly the same. And I would say that should be about all medical technology. I mean, that big equipment in the hospital also. I mean, why shouldn't it? What is its ROI?
I will make one comment about that. The question that came out though is that there was sort of this assumption that you can't solve problems for a small population. I actually think digital healthcare allows us to solve problems for smaller populations at a cost-effective manner, that you can actually not companies want to build products that are for, like the big companies out there, they want to build products that are for everyone. But actually there's a lot of problems in healthcare that are needed for smaller groups and populations. And so digital healthcare actually enables us to do that in a cost-effective way that drives value. So.
Great. Well, thank you so much. I think we could just continue with a lot of the questions. There's just so much to address in digital healthcare, but in interest of time, I just want to thank our panelists very much for being with us today and sharing their perspectives. And I know Nancy Nager, who's our president, just wants to take a minute just to talk to the group. So Nancy, go ahead, please.
Well, thanks, Amita, and thanks to the panel. This was fabulous. Such great information. We could talk about this for hours and hours. Then maybe we will kind of repeat this next year. I just wanted to thank Blue Cross Blue Shield, who sponsored our healthcare series this year. That we're thrilled that they were willing to do this, and it allowed us to have, you know, a really nice presentation in different topics throughout the year. So thank you to Blue Cross Blue Shield. And also just to remind people, this is a CEU program and a CME program. So this is the last of our series. So you'll be seeing an evaluation. We've done the CEUs through Cinemed, and we'll be awarding certificates after we receive the evaluation. So thank you again, and thank you to Amita for doing such a wonderful job.
Thank you, everyone. Thank you again, panelists and audience, and we'll see you again at another event. Thank you so much. Bye.
Good night.
Thank you.
Thank you.
Bye.